you very much, Laurent. I envy you your short sharing sessions. So in the next 15 minutes, we're going to talk about lung recruitment, the when and how. These are my disclosures. And I'm going to talk about recruiting the lung with PEEP, plus or minus recruitment maneuvers, with prone positioning, and then with alternate modes of ventilation. So PEEP and lung recruitment for ARDS is not a new concept. If you look in the original Ashbaugh and Petty description of ARDS in the Lancet from 1967, they discovered this button on the ventilator called expiratory retard, i.e. PEEP, and they were able to show dramatic improvements in oxygenation. In fact, most of the patients who survived their cohort did so after they discovered this expiratory retard button. From then we moved on, and this classic paper from Peter Suter and Barry Fairley talking about optimal PEEP, and we continue to debate what is the right level of PEEP today. Here they were focused on the PEEP that provided the best oxygenation and the best compliance of the respiratory system while still preserving cardiac output. So what do we do in usual practice? Over time, we've seen, I would say, a modest increase in the average PEEP set in patients who are labeled as by their clinicians as having ARDS, which is probably only a subgroup of the patients who really have ARDS. But I'll point out that most of this difference in the increase in mean PEEP has been the elimination of a small subset of patients in the late 90s and early 2000s who were being ventilated with very low levels of PEEP. More recent data from the LungSafe study, I'll just blow up this a little bit here, show that on average, we're not using very high levels of PEEP, and so people I don't think are really trying, in a lot of cases, to recruit the lung with PEEP. Even in the severe ARDS category with a PF ratio less than 100, the average PEEP applied was only 10 centimeters of water. Now, why should we care about recruitment and getting rid of atelectasis? I'll point out that atelectasis in and of itself is not necessarily harmful to the lung, or at least to the part of the lung that is atelectatic. This experimental study from Brian Kavanagh's lab nicely showed that when they looked at different sections of the lung, the area that the lung that had been atelectatic was actually relatively protected. And where atelectasis may be dangerous is it then reduces the size of the baby lung and exposes the rest of that lung to potentially more harmful stretch forces. So you take half the lung out of the equation, the rest of the lung has to compensate if you're still using a similar tidal volume. And so thinking about lung recruitment then makes sense if we know for sure we want to stay away from this zone of overdistension and cyclic overstretch. And we probably, in talking about recruitment, we're trying to stay away from the zone of de-recruitment and atelectasis, not necessarily, as I said, because atelic trauma may or may not play an important role in terms of the actual opening and closing, but because the more of this you have, the higher your risk of having overdistension. So, does PEEP work? Lots of people, were disappointed when you looked at the overall individual results from the alveoli trial, the LOVES trial, and EXPRESS study. But the truth is, there's probably significant heterogeneity of treatment effect, and high PEEP should not be applied to everybody with a label of acute lung injury. And this is nicely illustrated in this individual patient data meta-analysis, where when we took the patients with what was then ARDS, what we would now call moderate or severe ARDS, PF ratio less than 200, suddenly there is a statistically significant benefit from using a strategy of higher PEEP compared with a lower PEEP FiO2 table. And in fact, the converse is true in patients who only had mild ARDS, so PF ratios above 200. Recruitment maneuvers. If you're trying to open up the lung, we use oxygenation as a surrogate for lung recruitment here. There have been lots of physiological studies of recruitment maneuvers. Most of these, this is a systematic review that Eddie Fan conducted 10 years ago. Most of these are the short-term, sort of sustained inflation recruitment maneuvers, showing, in many cases, significant improvements in oxygenation, which likely reflects lung recruitment in many cases. But again, heterogeneity of treatment effect. This Luciano Gattinoni paper in the New England Journal 2006 is instructive when you look at who's recruitable and who's not, so in this study they simply took the patient to the scanner, did a scan at 5 centimeters of water PEEP, put the PEEP up to 45 centimeters of water and rescanned. And they divided the patients according to how much recruitment there was. This is a typical CT scan of a recruitable patient. So very, look at this, you say, oh, it's very nice. We got rid of all this atelectatic lung, it's now opened up here, perfect. Here's an example of a non-recruiting patient. So a couple of very important things to notice here. First of all, the starting point here looks kind of like the ending point of our previous patient. So many patients, at least in this study, who were not recruitable because their lungs were already open. The other very important thing to notice here is look at the heart. 5 centimeters of water PEEP, 45 centimeters of water PEEP, right? And you'll notice that didn't happen so much in the patient who was recruitable. So applying lung recruitment is something that can be helpful, but it shouldn't be done to every patient that you have on a ventilator, and it really should only be done to people who have some lung that could be recruited. Now, in recent years, we've seen lots of enthusiasm about these more prolonged, more aggressive staircase-type recruitment maneuvers. This is the schematic from the ART trial from Alexander Cavalcanti and colleagues, where they used incremental increases of PEEP with pressure-controlled driving pressures of 15 on top of that went on for several minutes and reached peak pressures of up to 60 centimeters of water, followed by a decremental PEEP trial, a sustained inflation back to the optimal, and then back to the optimal PEEP that was identified there. Initial data coming out of the Brazilian group showing that you could achieve fantastic looking CT images with this and really get rid of atelectasis entirely with this method. But does it actually work in clinical practice? Certainly some reason for caution here. The ART trial, as you probably know, was different than it was actually high PEEP versus reasonably high PEEP, certainly higher than was applied in the other higher versus lower PEEP trials. And it showed an increase in mortality in the lung recruitment group. My take on this trial is it's potentially difficult to extrapolate and generalize to the rest of the world. A lot of patients that had diseases that we don't necessarily see in Europe or North America. But I think it certainly gives us a little bit of caution about using these very aggressive and prolonged recruitment maneuvers and thinking about careful patient selection about when we're going to try and recruit the lung. Of note, FARLAP trial, which used a very similar approach, has been stopped early and results reported, not yet published. This is the phase 1, 2 version of it. They did not find any similar harmful effect as the ART did. Oh, it's a much smaller study. Now, as a first step, I think it's reasonable to think about PEEP plus or minus recruitment maneuver. If your patient is still quite hypoxemic and in need of recruitment, prone positioning should be your next step. And proning does result in lung recruitment. By having the bed prevent the chest from expanding forwards, you force the diaphragm downwards and we get significant lung recruitment of the basal posterior lung regions. And this is seen, you can see this reflected by oxygenation every time somebody was turned prone and turned back in this first Gattinoni RCT here. And not only does it recruit the lung, probably stabilizes and homogenizes ventilatory pressures well during ventilation and results in a significant improvement in mortality. In ProSiva here, even if you think, well, this is too good to be true, even if it were half as big as this, still be a very important effect. And you don't have to do one or the other. Proning and higher PEEP may be synergistic. In this mechanistic study from Chile, this group took patients in both the supine and position and studied them in the CT scanner on 5 and 15 of PEEP. And the group with the smallest amount of tidal volume recruitment and de-recruitment and the lowest amount of tidal hyperinflation is the prone group with the higher PEEP. Now, alternate methods of ventilation could be HFO, uses higher mean airway pressures to open up the lung, very effective in improving oxygenation, likely through lung recruitment. But as you know, when you apply this to all comers, no benefit to potential harm. Again, to the point of thinking about who you're going to recruit properly. In a secondary individual patient data meta-analysis of these trials, there's a subgroup of patients that actually benefit from HFO in terms of mortality, and it's the ones down here with the lowest PF ratio at baseline, probably the ones that had the highest potential for lung recruitment. Okay, but this is how we might do it. How do we assess it? How do you know if you're successful or not? Sometimes it's very obvious. You can see on a chest x-ray. You can use more sophisticated methods, as outlined here, during an decremental PEEP trial, looking at compliance, looking at saturation, can give you a clue as to where you've gone off, you've successfully recruited and then starting to de-recruit. A simple method, and if you think that ideally we want to be giving higher PEEP to and recruiting patients who have higher potential for recruitment, then the simple PEEP FiO2 table that was used in the LOVE study here has performed better than potentially more complicated things like the stress index or an esophageal balloon in this study by David Ciamello and colleagues. Finally, we could start looking at newer imaging to help us guide recruitment and let us know what's going on. And using electrical impedance tomography, a belt that goes around the chest and gives you a single slice of the lung, you can plot curves like this. These are two different representative patients where you can match over-recruitment and over-distension and find the point where you have the best balance between recruiting lung that could be recruitable and not over-distending lung that's already open. I'll skip this for the sake of time. One other idea to think about when to use higher or PEEP or not is to give a test dose. It's essentially what Ewan Gallagher tested here in the LOVE study database. He looked at patients, divided them into those who had their PEEP increased from baseline of randomization. And in those patients, when you looked at the change in oxygenation, looking at the first blood gas done after inclusion in the study, if your PEEP was raised and your PF ratio got better, your chances of dying were significantly lower. Conversely, if you put the PEEP up and the oxygenation got worse, those patients had a higher risk of death. No significant association when the PEEP was the same or lower as you would expect. So I tried to show you a few things that atelectasis is not harmful, but its secondary effects on the baby lung are. Successful lung recruitment is good, but increased PEEP without recruitment may be bad. Prone positioning recruits the lung and reduces mortality in severe ARDS. The when, I start thinking about this when the PF ratio is less than 200 and there's significant airspace disease seen on the X-ray or CT scan. How? I start with PEEP and some sustained inflation recruitment maneuvers, and then consider prone positioning. And in whom, stick with it in the ones who actually have a good response. And with that, I'll stop there and be happy to take questions. Thank you.